Hello, and welcome to another edition of the University of Alberta Plastic Surgery Webcast series, created by Dr. Gordon Wilkes, Dr. Kevin Mowbray, and Ashley Matkin. Today we're going to be talking about compartment syndrome. This webcast was written by myself, Ashley Matkin, and edited by Dr. Gordon Wilkes. In this presentation, we will describe compartment syndrome and review compartment anatomy for the upper extremity and lower leg. We will then address risk factors for compartment syndrome and touch on epidemiology of the condition before going through important aspects of history and physical exam. Differential diagnosis and investigations will be covered before detailing interventions. Finally, we will discuss the prognosis of the condition. So what is compartment syndrome? Compartment syndrome is an increase in interstitial pressure within a confined, fascially bounded space, resulting in compromise of the microcirculation. Increasing pressure in the compartment damages the capillaries, resulting in their collapse. This further aggravates the problem because the less sturdy venous and lymphatic capillaries collapse before the more rugged arterioles, meaning that while there is still an arterial supply to the compartment, there is no longer a way for the fluid to leave. Thus, the compartment pressure increases further, causing further outflow obstruction. While this is happening, the decreased perfusion pressure also results in local hypoxemia, and thus damage to cell membranes, resulting in further tissue swelling and increased compartment pressure. Compartment syndrome can occur in any fascially bounded tissue space, but the most common areas this condition will be encountered are the upper extremity and the distal leg, so we will be covering the anatomy of these locations. The upper arm has two compartments, anterior and posterior, which are divided by the lateral and medial intermuscular septum. The anterior, or flexor compartment, contains the biceps brachii, brachialis, and coracobrachialis muscles. This compartment also contains the brachial artery and the medial cutaneous nerve of the forearm. The median nerve crosses through the intermuscular septum between the anterior compartment and the posterior compartment. The posterior, or extensor compartment, contains the radial and ulnar nerves, as well as the three heads of the triceps muscle. The forearm contains three main compartments: volar, dorsal, and lateral. The volar, or flexor compartment, is further divided into a superficial and a deep compartment. These compartments are less completely separated than those of the arm, which means that a compartment syndrome in the forearm is likely to involve more than just one single compartment. Moving medial to lateral, the superficial volar compartment contains the flexor carpi ulnaris, flexor digitorum superficialis, palmaris longus, flexor carpi radialis, and pronator teres muscles. This compartment also contains the ulnar artery and nerve. The deep volar compartment contains the flexor digitorum profundus, flexor pollicis longus, and pronator quadratus muscles. This compartment hosts the anterior interosseous nerve, which is a branch of the median nerve, as well as the ulnar and common interosseous arteries. This is the most common location for a compartment syndrome of the forearm. The dorsal, or extensor compartment, contains the anconeus, extensor carpi ulnaris, extensor digiti minimi, in this diagram labeled EDQ, as it is also known as the extensor digiti quinti proprius, the extensor digitorum communis, and the supinator muscles and tendons. This compartment contains the posterior interosseous nerve, which is a branch of the radial nerve, and the posterior interosseous artery. The lateral compartment, also known as the mobile wad, consists of the brachioradialis and the extensor carpi radialis longus and brevis muscles, along with the superficial branch of the radial nerve and the radial artery. The hand has 10 separate compartments. The thenar compartment is comprised of the thenar muscles, abductor pollicis brevis, flexor pollicis brevis, both the superficial and the deep heads, and opponens pollicis. The hypothenar compartment contains the hypothenar muscles, abductor digiti minimi, flexor digiti minimi brevis, and opponens digiti minimi. The oblique and transverse heads of adductor pollicis comprise the adductor compartment, and then each of the 3 palmar and 4 dorsal interosseous muscles make up the remaining 7 compartments, so named for their respective muscle. The distal leg is composed of the anterior, lateral, and posterior compartments. The posterior compartment is then separated into a superficial and a deep compartment. The anterior compartment is the most common site of compartment syndrome in the leg. It is made from the borders of the tibia, the fibula, the interosseous membrane, and the anterior intermuscular septum. This compartment contains the tibialis anterior, extensor digitorum longus, and extensor hallucis longus muscles. Also found within this compartment are the deep peroneal nerve and the anterior tibial artery. The lateral compartment is the second most common site of compartment syndrome in the leg. This compartment is formed by the fibula and the anterior and posterior intermuscular septums. It contains the peroneus longus and brevis muscles, as well as the deep and superficial peroneal nerves. The superficial posterior compartment is bounded by deep fascia and contains the gastrosoleus complex and the sural nerve. The deep posterior compartment is bordered by the tibia, the fibula, the deep transverse fascia, and the interosseous membrane. It contains the tibialis posterior, the flexor hallucis longus, and the flexor digitorum longus muscles, as well as the tibial artery and nerve. Of note, the tibialis posterior muscle appears to have its own fascial layer, and thus some categorize it as a separate 5th compartment of the leg, rather than as a part of the deep posterior compartment. Now that we know the basic etiology behind compartment syndrome and some of the relevant anatomy, we can address the causes of this condition. There are a number of risk factors for the development of compartment syndrome, which are responsible for one of 2 mechanisms. Either the compartment size is reduced from external compression, or there is increased volume inside the compartment. External compartment size reduction can be caused by a tight cast, extended duration of a tourniquet, a crush injury to a closed compartment, existence of non-expandable burn eschar, or from lying on a limb for a prolonged period of time, such as when a person is unconscious. Increased compartment volume can result from hemorrhage, most often a fracture or crush injury, or in those with a bleeding disorder or on anticoagulation therapy, arterial occlusion ischemia, venous obstruction, edema, electrical shock, severe burns, reperfusion injury, intravenous extravasation of a toxic substance, or injection of a toxin from a snake bite. It is important to note that although open fractures are associated with the laceration of the compartment, this laceration may not be sufficient for decompression, and compartment syndrome is still a potential complication of the injury due to hemorrhage. 6 to 9% of open tibial fractures result in compartment syndrome. One must also be cautious when repairing finger injuries, as a ring block can result in compression syndrome of the hand. Also, it is important to note that supracondylar fractures are the most common cause of compartment syndrome in children. Compartment syndrome occurs in a 10-to-1 male-to-female ratio at an average age of 30 years old in men and 44 years old in women. Compartment syndrome usually presents within 36 to 72 hours of the onset of traumatic injury. The most common injuries associated with compartment syndrome are high-energy injuries of the tibia, followed by high-energy injuries of the forearm. You will likely begin to suspect compartment syndrome in a patient with excessive pain in a limb or hand. When ruling compartment syndrome in or out, it is important to ask about the aforementioned risk factors, particularly the mechanism of injury and any bleeding disorder or blood thinning medications that may cause excessive bleeding into a compartment. The classic cardinal signs of compartment syndrome, known as the 6 Ps, are pain, pallor, paresis or paralysis, paresthesias, pulselessness, and poikilothermia, or reduced temperature of the affected limb. These, however, are late signs of compartment syndrome. Don't wait until you see all of these signs to suspect compartment syndrome. The first finding of compartment syndrome is usually pain with passive extension and loss of fine touch sensation. Other earlier findings include palpably swollen or tense compartments and decreased active movement. It is important to note that a loss of pulses is a very late sign of compartment syndrome, so the presence of pulses does not rule the diagnosis out. The most important part of physical exam for compartment syndrome is awareness and early suspicion. If compartment syndrome is suspected, but the diagnosis is unclear, serial examination is important as the pressure in the compartment can continue to increase for up to 48 hours post-injury or surgery. Intrinsic muscle weakness in the hand can be a sign of compartment syndrome of the deep muscles. This can be prevented in burn patients by performing escherotomy of the hand if needed in the immediate post-burn period. Volkmann's ischemic contracture of the hand, as seen in this photo, can be caused by muscle ischemia and necrosis from unrecognized or undertreated compartment syndrome of the forearm. Diagnosis of compartment syndrome is primarily clinical, but important differentials to keep in mind include cellulitis, deep vein thrombosis, a necrotizing soft tissue infection, gas gangrene, a peripheral vascular injury, and rhabdomyolysis. Definitive diagnosis of compartment syndrome can be made by measuring intercompartment pressure and calculating a differential pressure by subtracting the compartment pressure from the diastolic pressure. Absolute indication for fasciotomy is a differential pressure of less than 30 millimeters mercury, although some use an absolute pressure of 30 millimeters mercury in the suspected compartment as an indication for fasciotomy. One should always perform a fasciotomy if there is a high suspicion of compartment syndrome, as a missed diagnosis can lead to ischemic necrosis of the limb and deformities such as the Volkmann's contracture. This is a greater morbidity than the morbidity in an unnecessary fasciotomy. Compartment pressure can be measured in different ways. The most common and most accurate way is to measure intercompartment pressure by using commercially produced products such as a Stryker needle. If a Stryker needle is not available, however, the less accurate needle technique is able to be performed with equipment that can be found in any emergency room: an 18-gauge needle, 2 lengths of IV tubing, a stopcock, a blood pressure manometer, and a syringe. We'll walk you through this method. First, you attach a length of IV tubing to the 18-gauge needle and fill approximately half of it with sterile saline. Ensure there are no air bubbles. The stopcock is attached to the other end of the tubing with a second length of IV tubing connected opposite to the first, and the blood pressure manometer attached to the opposite end. Then attach a syringe to the third opening of the stopcock. Keeping the entire apparatus level with the needle, insert the needle into the compartment and turn the stopcock so it is open in the direction of the IV tubing. Slowly compress the syringe, moving air into both sides of the extension tubing, while watching the saline meniscus in the tube attached to the needle for movement. Once movement is observed, immediately read the compartment pressure on the manometer. Recalling the compartments and anatomy of the leg and forearm, it is possible to determine which compartment is affected based on physical exam. For example, compartment syndrome of the anterior compartment of the lower leg will result in a tense or tender anterior leg, pain with passive toe extension, and possible sensory loss in the first web space due to compression of the deep peroneal nerve. This point is merely academic, however, as it is typically recommended to release all compartments when treating compartment syndrome. If a patient is experiencing tingling and increased pain in their limb on passive extension, but has a compartment pressure below 30 millimeters mercury, major limb elevation and IV mannitol can be used to treat their symptoms before deciding to pursue fasciotomy, but serial reassessments are of the utmost importance in this case. We will now go through appropriate fasciotomies for compartment syndrome in the upper extremity, including the hand, as well as the lower leg. Fasciotomy of the brachium requires only one incision along the lateral aspect of the arm, from the insertion of the deltoid muscle to the lateral epicondyle, avoiding damaging the larger cutaneous nerves. Through this incision, the intermuscular septum between the anterior and posterior compartments of the arm can be visualized, and each compartment can be released with a longitudinal incision up the fascia. Note that the radial nerve passes through the intermuscular septum as it travels from the posterior to the anterior compartment. Ensure you identify and protect this nerve. Fasciotomy of the forearm requires 2 incisions. A longitudinal incision along the center of the extensor surface reveals the dorsal compartment for decompression. The volar compartment and mobile wad are identified through an incision along the flexor aspect of the arm, beginning at the antecubital fossa. The incision curves across the elbow flexion crease from the radial aspect of the fossa toward the medial epicondyle, and continues distally down the ulnar aspect of the volar forearm, where it crosses the wrist flexion transversely. The carpal tunnel can be released with a palmar incision between the thenar and hypothenar muscles. Next, the superficial and deep volar compartments can be identified and released, followed by the lacertus fibrosus at the elbow. This is a fibrous band that overlies the brachial artery and median nerve. Be careful to preserve these structures. If release of the mobile wad is desired, a second straight incision can be made on the dorsum of the forearm. Because the hand has 10 compartments, fasciotomy consists of 4 incisions located as follows: the radial aspect of the thumb metacarpal, the dorsal aspect of the D1 metacarpal, the dorsal aspect of the D4 metacarpal, and the ulnar aspect of the D5 metacarpal. The incision along the thumb releases the thenar compartment, and the ulnar D5 incision releases the hypothenar compartment. The dorsal incisions provide access to the interossei, the volar interossei, and the adductor pollicis muscles. The 4-compartment fasciotomy of the lower leg can be done in one of 2 approaches: via a single incision or with 2 incisions. There is no clear evidence as to which one is superior. However, the 1-incision technique does pose a greater risk of injury to the peroneal artery and nerve due to the reduced visualization of the deep posterior compartment. A single skin incision is made just inferior to the fibular head, 1 to 2 centimeters anterior and parallel to the fibula, and 3 to 4 centimeters proximal to the lateral malleolus. The anterior and lateral compartments can then be visualized through creation of an anterior flap, and longitudinal incisions can be made in each of these compartments. Ensure you visualize and avoid the common, superficial, and deep peroneal nerves at the fibular head. The superficial posterior compartment can then be visualized and released with a longitudinal incision in the fascia by creating a lateral flap from the initial skin incision. Be sure to identify the gastrocnemius muscle. In order to visualize the deep posterior compartment, the soleus muscle must be dissected. The fasciotomy can then be performed at the medial border of the fibula, taking care to protect the peroneal vessels. In the 2-incision technique, the lateral and medial incisions, which can be up to 30 centimeters long each, completely release all 4 compartments. Both incisions are landmarked from the anterior border of the tibia, with the lateral incision being 5 centimeters lateral and the medial incision beginning 2 centimeters medial to the tibial margin. The lateral incision should begin distal to the fibular head to avoid damaging the common peroneal nerve, and end 5 centimeters above the lateral malleolus, exposing the anterior and peroneal compartments. Identification of the intermuscular septum ensures both compartments are released. Before releasing the posterior compartments through the medial incision, identify and protect the saphenous vein and nerve. Incise the gastrocnemia fascia longitudinally from proximal to distal to release the superficial posterior compartment, and then divide the attachments of the soleus muscle to the tibia to release the deep posterior compartment. Compartment syndrome treated with timely fasciotomy and delayed closure has good outcomes. If untreated, the continuing increased pressure will compromise the compartment microcirculation, which can lead to neuropraxia and muscle necrosis. Further progression can result in irreversible axonotmesis and subsequent limb ischemia. The best way to improve outcomes is to have a low index of suspicion for compartment syndrome and treat with early fasciotomy to prevent permanent muscle necrosis and nerve injury. Permanent muscle necrosis can develop after 4 to 5 hours, and nerve injury begins as quickly as 30 minutes post-injury. Indicators of poor prognosis include treatment initiated greater than 12 hours from symptom onset, cardinal signs of pallor, pulselessness, paralysis, and poikilothermia. Thank you so much for listening today. I hope this was educational, and tune in for more podcasts on various plastic surgery presentations.